February 4th is World Cancer Day. It is a time for awareness, a time to know about early detection, and a time to support those who have been affected. Today we're going to be speaking with oncology specialists who will tell us the reality of cancer and what we can do to save ourselves and our loved ones. I'm Faith Oyewole, and it is time to get aware. Good morning, ma'am.
Good morning.
So let's get to meet you, ma'am.
Alright, so I'm Dr. Latunji, I'm a consultant radiation clinical oncologist, oncology department, LASUTH, and what we do here basically is we manage cancer. There are different modalities that we use to treat cancers, chemo, radiotherapy, targeted therapy, immunotherapy, surgery. And we have the surgical aspect that we refer to our surgeons in the hospital.
Thank you so much, ma'am. That is a beautiful one for the female doctor. That is beautiful. Let's go back. Let's get serious right now. So, ma'am, we're talking about getting away about cancer. Can you tell us what cancer really is and what it is not, and how we can actually get to know that okay, this what you have right now is cancer?
All right. So, cancer is an abnormal growth. The characteristics of abnormal growth in the cells, and if it starts to grow from there, it can go to other distant organs. Alright, so basically God has designed that when cells grow, they grow old and they die. But in cancer, there is continuous growth. It's a programmed cell death naturally, which is a natural process there. If there is mutagenesis or whatsoever, such that the DNA is damaged, when it's supposed to die, it doesn't die, and the cells keeps multiplying. This can occur in those cells, and it can be in any part of the body. This body is made of cells. I mean, growth and life starts from one cell that multiplies and all that. But like I said, there is supposed to be a programmed cell that when it grows to a certain level, growth is supposed to be limited. But when there is mutagenesis and there's damage to the DNA, those cells just continue to grow haphazardly. And when this happens, they can even go to such an extent that it will go to the surrounding structures. This is why we say the cancer is locally advanced cancer, or it can actually go to distant organs. I mean, talking about the liver, the lung, the bone, the brain. Those are particular areas. And how do they spread? They can go actually through blood supply or lymphatic supply. So that's basically what cancer is all about.
So what are the risks?
Alright, so we have modified and non-modified risk factors. Modified risk factors are the ones that you have power over. The non-modified risk factors are the ones that you don't have power over. I will talk in terms of cancers that are common in male or some that are not common in female. Generally, some of them have same predisposing factors or risk factors. Modified risk factors are the likes of sedentary lifestyle, alcohol, and if you don't move around, inactivity and all that, accumulation of fats, and be a basket of events such that cancers can come up, right? We're talking about tobacco smoking and alcohol. Tobacco, everybody knows that it's culpable in lung cancers and also in other forms of cancers too. Even in breast cancer, in cervical cancer, they are culpable. The ones that you can avoid, talking about cervical cancer, the human papillomavirus, how do patients don't get it? It's sexually transmitted, right? Sexual exposure before the age of 18, multiple sexual partners, even when people that are married or people that even have partners that have multiple sexual partners, they can be infected with human papillomavirus. You have a power over promiscuity.
Yes.
You have a power over promiscuity. You can choose to be on your own and you can choose not to be on your own. The oral contraceptive is culpable in breast cancers as well. Exogenous estrogen or hormonal intake in postmenopausal women. Some patients say, okay, we know that the feel-good female sex hormone is estrogen. it makes the breast pecky, it keeps and maintains the feminine nature, the moves and all that. So when they get to postmenopausal state, it's depleted, they begin to have hot flushes and all that. So when they see the doctors out there, they tell them, okay, maybe they give them the option of hormonal replacement, external estrogen replacement. But guess what? It's really not necessary. I mean, because it's responsible for some other cancers, even talking about the breast cancer, the oral contraceptive pills, all this hormonal supply, they also affect the breast, ovary, and all that. You see all those patients that they say, okay, they have fertility issues, they give them hormonal challenge, all this at the end of it all can turn around and come and give them cancers. I've seen patients that that had to implant that and not plants as contraceptives, and I've seen like 3 or 4 cases. It's more than 4 cases in my years of practice. Oh, did you use oral contraceptive? Or some of them say, some use, and by the time you trace the history, is one of the risk factors. Or some with the no plans, but say, oh, that she got married, that she didn't want to have children immediately, or they just kept it there after a while they developed breast cancer. Because when this patient come along, we do our clicking, take histories and all that. Why are we doing those clickings? We're doing to get clinical history. I mean, trying to pick up the risk factors that could have exposed this particular patient in this situation to the current cancer that we're talking about. So those are part of the modifiable risk factors. So we encourage our patient to do exercise, no smoking, no alcohol, healthy behaviors. And some patients, it may be other infections. Like you are talking about hepatitis B infection, all right? I know I mentioned avian papillomavirus is also infection, part of the cause. Talking about hepatitis B, some patients that have hepatitis B cancers and that have not been vaccinated in the past.
Okay, we talked about different cancers, and I picked about 2 questions from everything you said, but let's start from one. About the vaccine. I remember when the awareness for the vaccine started, and there were rumors, different kind of rumors about the vaccine. People were saying, if we take it, we will die. Rumors about all these things and all. I feel like it started from somewhere. Where could the mistake come from? Let's start from there. And again, at the end, for them to actually put their mind at rest, is there any danger in taking those vaccines?
All right, so I think the genesis of this problem is lack of awareness. People should be more enlightened. There should be more awareness. I know there's been a whole lot ongoing on the social media, on the radio, on the television, announcing, and even in the localities, you see people going around talking about vaccination and all that. I think if people are more aware that the benefit outweighs whatever it is they're thinking about, then people will come out further to come and receive those vaccinations. I think the major problem, like I said, there is actually no excuse for ignorance. It's ignorance and lack of awareness. All right? And okay, since just like you said that you received the vaccine and nothing happened. I remember the COVID vaccine then when people were saying don't take, and people were dying off. We are frontliners, we had no choice. We have to take it, and here we are. I'm glad you also said you received. And yet, even the hepatitis B. You can imagine if we had not been. We've had several exposures to patients, to blood. The hepatitis B vaccine. If it's dry and it's here, go back and come back. You have sores. You can catch it. All right. So it is very important that people get vaccinated. For me, I think we should try to eradicate ignorance. There should be more awareness. If we have more awareness, you know what you hear every day. By the time you start listening to it every day, it will be in your subconscious. And before you know what's happening, you go out there and go and do. And I thank God that they also reach, the awarenesses are getting to the schools.
Thank you so much, now. So this brings me to my next question. Before I ask, vaccination will not kill you, okay?
So we need to correct that notion.
Yes.
It won't kill.
So bringing me to my next question. It's part of the question I want to ask, but you touched it the lockdown before, like I hear me. You talked about prostate cancer. Talked about the fact that okay, it can be genetic, it can be in the family. Now, I know that some cancers can be prevented. Like you mentioned that the one that is caused by alcohol, tobacco, maybe if you stop using. And now I've been on the street before, and the cancer that people know is the one that is caused by either alcohol or cigarette, and the other ones they do not know about. Now, how do you prevent all this, apart from the ones that are genetic? Okay, the ones that is caused by maybe what you take or what you do causes it. How do you prevent it from actually eating you up to the point whereby lives are lost?
Alright, so the thing here is screening. We do not have the screening culture. Our people do not have the screening culture. I think more noise and enlightenment should be done, or more noise should be made, such that people are aware that although there's cancer, it's not a death sentence if you catch it early. Early diagnosis saves life. If people go out for screening, like apart from the genetic factor and everything, I mean, people should just go out and do their. Some people have they even ever done colonoscopy? Have they ever done breast ultrasound scan? Have they ever done pap smear? All right. We need to enlighten people and let them know that we're not saying you have cancer, but let's have the screening culture. Go for screening. All right. For people less than 40 years, do they know how to do their breast, for everybody, breast self-examination? I mean, do you stay in front of a mirror? Do you know what the normal looks like from the abnormal? We know that as female, there are many physiological changes that occur in the body from the mid-cycle, where you have fullness, to the period, to the menses, end of the cycle, where you have, the period is coming, there's fullness, there's tenderness. Some people know when they're ovulating because their body is really very sensitive. They can tell. So you know the changes that occur in your body at certain times of the month. Do you know what the normal feels like? Okay, do you know the texture of your breast? Because some breasts are very soft, some are really dense, they are fibrous and dense. Okay, so those ones with the fibrous and dense breast, do you know what it feels like? The moment you feel the hardness, or you feel a lump, or the breast feels heavier, does it strike you that this is abnormal? All right. So we need to counsel them on ability to know what is normal from abnormal. Okay, for people less than 40 years, you should be, after the breast self-examination, clinical examination by the doctors, do you go for ultrasound scan? For people above 40 years, do you go for mammo? All right. So are you doing that? And now there's even a higher, a more advanced imaging that picks really tiny even nodules if there's anything. If you are doing it, you can pick it. That's an MRI, breast MRI. No matter how small it is, it's going to pick up the lesion. So are we going for that? We should encourage people to go for that. All right. Colonoscopy. Are we doing colonoscopy? That's what they say before the age of 40. But for now, I just encourage people, even in your 30s, go for it. Then, particularly if you have family relatives that have this situation, you should, like 10 years before their age, the age that the disease came in them, we should have started screening. Like those with positive family histories now. Like 10 years before then, we start screening for that thing, for that kind of situation. So are we doing that? Then are we making it a culture for even people that do not even have the family history of that colon cancer or the breast cancer? So what are we doing about it? Then pap smear, are we doing? You're sexually active, are you doing your pap smear? Your partner, how faithful are they? Do you even know? Are you, you have multiple, you have multiple sexual partners. What are you doing to yourself? Are you trying to caution yourself, knowing that, even papillomavirus is spread through sexual activities, and if you have multiple sexual partners, you can get it, or your partner, or you are faithful, and your partner is a partner, all right too. So screening in both ends, all right. So have you done your blood work? Are you hepatitis B positive? Are you screening in that light? You know that if you catch it early, we will be able to do something about it. But if we don't catch it early, the disease will have been advanced. So if we do that screening and we pick it early diagnosis and prompt treatment, because sometimes it's not even all about the early diagnosis. If you diagnose it, then prompt referral, because some centers, they pick up the disease and some will even keep the patients. We've seen several situations like that even people that are not oncologists, they are able to do the screening, they've done the screening, they have the diagnosis, and they keep the patient, not knowing that they don't have the capability and the knowledge, but the fact that, maybe we can make money from this, they'll keep those patients over there. And by the time the disease is really advanced, then they send the patient out and all that. So we should all encourage ourselves to do the right thing, all right? Improve our culture of screening, prompt diagnosis, prompt referral and diagnosis, and prompt treatment to centers that are able to do all this, all right? So it's not a death sentence in actual sense, but if you catch the disease early, say, okay, look at it now. We have four different stages of cancer. If you catch it at stage 1, oh, fantastic. If you catch it at stage 2, oh, good. One is the best, or at all maybe pre-cancer. If you catch it early, you can deal with it, all right? So if you catch it at stage 2, we can't manage, we can't. Stage 3, we are tending towards 4. Stage 1 is when it's just limited to that organ. Stage 2 is in that organ, maybe in the lymph nodes, a little bit bigger, or going to the lymph. Stage 3 is when it's locally advanced. It's big where it is, it has formed branches and all that, all right? Just involving the local lymph nodes or structures around, all right? So when it's stage 4 means when it has entered other organs, all right? Distant organs, like is in the lungs, is in the liver, is in the bone, is in the brain. That's it. So at that junction, you cannot you cannot cure the cancer. What you are doing at stage 4 is you are improving the quality of life. You are trying to control the disease. But at stage 1, 2, 3, you can also, at that point, you can still cure the disease. And mind you, the how you know the outcome of a treatment is this: the stage of presentation. I just mentioned that. If a patient presents late at stage 4, what are you trying to do? We're just doing palliative care, trying to control. If you still present at stage 1, 2, and 3, you can still go ahead and manage, all right? Then another thing that would give us an outcome is the grade of the disease. The disease can be grade 1, 2, and 3, all right? Grade 1 being, oh, it's not aggressive. Grade 2, I have a bit of aggressiveness, I have a bit of indolence in me. Grade 3 is when the disease is really advanced, all right? Grade 3 is when the disease can really spread. What it tells you that is aggressive. You can see a patient present at stage 2 and with a small lesion. Patient can present with a small lesion with high-grade disease, and before you know what, by the time you do your staging investigation, the disease is everywhere. And you are wondering, it's just a small lesion. How did it go? What it tells you is that it's an aggressive disease that can really spread on time. And for those ones that are really grade 1, that are really not, the indolent one, it can be this big and it's just remaining in that area and it wouldn't have gone. So that one also is another factor, the grade of the disease. I mentioned the stage, I just mentioned the grade of the disease. Then the performance status of this patient at presentation. Is this patient fit enough for treatment? And if a patient presents at stage 4, like I saw a patient last week Friday, and he said it's a prostate cancer case. The patient came in on a wheelchair. Obviously, they didn't present on time. So he had gotten to a state where the cancer had gone to the bone. All right, but we don't have histological diagnosis. So I said, okay, let's hurry up, get this patient stabilized. Let's take sample, because you need tissue diagnosis. We cannot manage cancer without knowing what it is. You need to take sample from whatever organ the cancer is arising from. So we planned for prostate biopsy. If you're going to do prostate biopsy, you need to prepare this patient, biopreparation, so they will be faces around the board, so that when they're taking the sample, they're able to do it and all that. So under ultrasound guidance. So we planned the patient for ultrasound guidance, ultrasound guided biopsy on Monday. And lo and behold, on Sunday, I was called by the patient's relative that, patient has some complication, there is blood accumulation, this and that, and so which necessitated the patient to be quickly seen by a urologist. So the patient came into the hospital. You see that the narrative is changing. This patient did not come on time. This patient did not have tissue diagnosis. All right? We're trying to expedite action on that, but while we're still doing that, there was a complication that arose. So we had to halt everything we had planned for Monday to see how we can stabilize this patient. This patient wasn't stable until like midweek. All right? By midweek again, patient deteriorated. By midweek, they're taking they succeeded in taking the biopsy. And lo and behold, the patient deteriorated. So we were not able to do any treatment per se, or just give best supportive care until this patient is fit enough for treatment. you see where the stage of the disease is now. The age of the patient matters. For young, vibrant patients, there is so much you can do for them. Even if they present late, they're still young and vibrant. So that means they are still able to tolerate aggressive treatment. But in the elderly, what more can you do? You really cannot do too much. You need to take it easy. As a matter of fact, when we're taking treatment decisions, we think of the age of the patient. We think of the performance status of the patient. If the patient performance status is poor, leave the patient. Try and see if you can boost the patient up to such a state that the patient will be able to tolerate the treatment. But if the age of the patient, if the patient is elderly, what are you trying to achieve? And somebody that's 90-something years old with colon cancer, you want to kill the patient, or what are you trying to do? So we factor all those into treatment decision making, all right? And also that will also determine the outcome. Then another thing is the patient's choice. Patient's choice. Some patients come in, you see them, you've taken, okay, this is what I need to do. Either they present early or mid or late presentation. Oh, madam, you come in with a long, oh, it hasn't spread, we've done all the regular investigations, all right? Let's take biopsy. Some patients will be surprised. You beg them for you to take biopsy. Some even refuse biopsy and say, God will do it. You see all sorts of things. So you take the biopsy, you have a diagnosis of cancer, and you tell them, oh, madam, this is, oh, madam, or sir, this is our treatment plan, let's do this. If we need to quickly do chemotherapy or we need to go for surgery first, you tell all those patients. And guess what? Some patients will tell you, no, I want to do the alternative route. And as doctors, as oncologists, we know that if we leave those cancer cases, it will start progressing. We've seen several cases. Patients will come in like that, and at the end of it all, they come back when they're stage 4. And you really cannot do anything. And at stage 4, they say, doctor, I'm ready for treatment. It's already too late. You really cannot do much for them. So what can you do if the patient says they don't want to receive treatment? All right? The patient's fertility too. These are also factors that we need to consider. For patients that haven't had children or patients that are in the younger age bracket, we just encourage them, we tell them, go and do egg banking and all that before we start any treatment. I mean, they want to have children. Imagine a patient that has ovarian cancer. When do eggs get produced? Bilateral ovarian cancer, and they still want to have children. And unfortunately, the 2 ovaries are involved. You need to start treatment in that. So how will they have children? All right? Or imagine a patient that hasn't, okay, because there was a life situation. I remember years back, I managed this woman with endometrial cancer. She didn't even know she had cancer. She had fertility issues. She wanted to have children, and they were planning for IVF. While they were planning for the IVF, she went to the hospital. So part of the test investigation they have to do to be sure that she's viable. So they did endometrial biopsy. And lo and behold, there was a high-grade uterine cancer.
Good.
Yes, it was a high grade. And so I don't know what happened. They were careless about it. They didn't do anything. The result arrived, they didn't do anything, and they altered the fertility issue. They altered it because she was already on some medication, so they altered it. But the ovarian cancer was not managed. She said they felt since they altered the hormonal medications and all that. And lo and behold, this woman, by the time she came back, the cancer had spread to the lungs. And so I was called to see. So situations like that are very painful, that we could have been able to save this patient. All right? She did not know. It was because they were in the process of getting to do investigation, pre-fertility, because the uterus you are going to do implantation, that uterus must be healthy. All right? So we see a lot of situations like that. I pray that this interview gets to a lot of people and they really become aware that some of these cancers are preventable. Some of them, even if you catch it early, you can still manage them. So where the problem comes is late presentation, or you are aware. Some patients claim ignorance until the disease is late, and you really cannot do much. So we encourage our people to do their screening, be cancer aware. You know, I've seen situations whereby even some patients, They bring other patients. Oh, my neighbor, she had this and this, and I told her I come from oncology clinic and this, and that was how they're able to get their own diagnosis. I've had a situation where I went to a supermarket and I think it was a pharmacy. So I saw a lady, she had breast asymmetry. Being an oncologist, I knew something was wrong. Breast asymmetry that was irregular, her disease was pretty advanced. So I could see. So I just went close to her and said, Madam, sorry to bother you, I'm not being nosy, but this is who I am, I'm so person. So is your breast hurting you? Do you have, she was shocked and she looked at me. I said, please don't be. I'm a doctor and this is why I manage cancer. And she was like, yes, doctor, yes, doctor. This is what have you done? She had not done anything. And her disease was pretty advanced, such that the breast had auto-amputated, all right? The lesions on the chest wall. Because she works on the ministry, she's packaging. But somehow I still got to know that something was amiss on her chest. So I was able to counsel her, and she came to see me in clinic. So we have situations like that. If we are aware that this is what is ongoing out there, we can be our neighbors' keepers. We can talk to our neighbors, we can talk to our friends and all that. If we're open about it. I mean, like I mentioned, there are some patients that are on treatment or even awareness. I mean, I've gone to churches to do talks and all, and you'll be amazed the number of people that have that condition in the congregation that did not even mention anything. But the fact that we were there to do the awareness, I know I've been able to manage like 8 patients that have come across through outreaches like that. All right? So cancer is there. There's no reason to be ashamed. And when they come to the department, they say, Doctor, are you serious? Everybody has cancer. This is a cancer managing department. So cancer is real. It's out there. Everybody has to be aware. You need to know your body. Know what is normal. Know what is abnormal. Know your breast. What it feels like in whatever time of the month. Go for your regular pap smear. Alright? I've mentioned earlier that people that are not sexually active, they should do this. And if you know you are sexually active, know what your partner feels like. Go for your screening on time. It's not your fault if you are faithful and you have an unfaithful partner that is just going everywhere. And we've seen situations like that. I've seen a politician's wife that she didn't even know her husband had HIV. Yes, she didn't know. Her husband was on anti-HIV drugs and he was hiding it from her. And with the low immunity, you are susceptible to quite a number of this. Take it for cervical cancer now. Low immunity is also a risk factor. Apart from human papilloma virus, HIV is also a risk factor because there is immunosuppression. All right. So in that kind of, she didn't know. Her husband was everywhere. He was in town, and she was just there. The doctor advised him to tell his wife so that she also can be covered. He didn't do that, so that woman got infected with HIV. All right, don't forget with that. That woman came down with cervical cancer. Yes, she did. Yes, she did come down with cervical cancer. Her immunity was low. Husband has multiple sexual partners, and she was just there at home. HIV, cervical cancer. She was devastated. So we see every day real life situations like that. So I mean, in a nutshell, what have we been talking about? What have we been talking about? Awareness, screening, early presentation. All right. Then we should be true to ourselves. Abstinence, if possible. Stick to one partner. Go for your regular screening. Know what your body feels like normal. And if you have a family history of cancer, be more proactive. Start your screening early. All right. For people whose mothers have first-degree relative have breast cancer, they have a lifetime 5 chance of having the cancer. So early screening. For people under 40, if your mother had breast cancer at 40, from age 20 itself, I've seen cancer in under 30. Yes, I've seen breast cancer in under 30. I've seen. And the sad thing there is that when we see this cancer in this our younger age group, they are more aggressive. The variant they are more aggressive. So if there's a positive family history, do the needful. Start doing your screening earlier. Make sure you make it a culture do your screening and get tested at often. Know the normal from abnormal. And when you find it, if there is anything, please do not be ashamed. Please come forward. Come forward. If you don't want to go with your people, just go privately, make inquiry where you think you can get help. If you go to a place and you're not satisfied, get a second opinion. All right? Second opinion matters. I mean, some patients are diagnosed, they are not comfortable. Come, ask for the centers. Ask for oncology centers, not just private centers oncology centers. We have private oncology centers. If you can afford it, we have government institutions. Ask of the oncology departments in those centers and come forward for proper treatment and management.
Thank you so much. Actually, it's funny how I want people to get aware, but I'm the one getting aware here right now. It's actually been a lovely session with you. Okay, we're still in the process of getting aware. It doesn't end here. It still continues. Stay with us and stay tuned. And yes, we are back again. Remember I told you to stay tuned that we are still getting aware. Yes. It's funny how we didn't know that so many things could actually cause cancer. Like today, I also learned that even having multiple sexual partners can actually lead to cancer. And we're still getting aware. And today, we are moving in and talking to another oncology specialist. Someone who is also brilliant. I told you I've met brilliant doctors right here in this hospital, and I tell you, I think in my next life I'm going to be a doctor. I'm just joking. So, can we get to meet yourself?
I'm Ademola Oyekon. I'm a consultant radiation and clinical oncologist with special interests in breast cancer, prostate cancer, sarcomas. Right, so I've been doing this for the past 7 to 8 years.
So I'm actually going to start from what you just mentioned. I've learned a lot from the female doctor about breast cancer. This prostate cancer you talked about. Let me be right about the pronunciation. Prostate cancer. Prostate cancer. Now, what exactly is the cause of it? Because social media can actually lead people to get the wrong thing. But I remember I've seen on social media that people are saying that if a man, for example, you're still young and you've not started having sexual partners, that is what causes prostate cancer. But I want to know the truth. What exactly is the cause?
All right, so thank you for the question and the clarification. So prostate cancer is a cancer that arises from the prostate gland. The prostate gland is one of the glands in the body that produces the components that makes up the semen. It's important to know that for majority of cancers, there is no singular thing that you could identify as a cause. However, there are risk factors. Risk factors are things that if somebody is going to have a thing, things that will increase their risk or predispose them to having it. So there are risk factors. And older age increases the risk. That's one of the risk factors. So risk factors, basically, they can be classified into modifiable and non-modifiable. Modifiable being that you can do something about them.
Yes.
Non-modifiable being that you can't do anything about them. So increasing age is a non-modifiable risk factor. You can't do anything about increasing your age. Family history is a non-modifiable risk factor. So if somebody has had it in the family, maybe a brother or a father, it increases the risk in the person. All right. Some genetic mutations, that's heredity, that's either you inherit or mutations that occur in that person while the person throughout that person's life. So those things can also increase the risk. Then the non-modifiable risk factors are basically are associated with the lifestyle, um, obesity, um, the type of food we eat.
Thank you so much for that insight. So you're trying to tell me that the rumors that were going on social media about the cause of prostate cancer is actually not really the cause.
No, no, not exactly. It has nothing to do with it. I've heard things like people saying the number of if you are married and you are not having sex for 21 days in a month or something, or ejaculating 21 days in a month, that you may be at risk. That's not true
Wow.
at all. One of the things that are protective against prostate cancer is amongst people that are eunuchs, people that have been castrated, all right? Maybe they decided to give their life to service to God and they have been castrated so that they won't be able to have any children. So, because the castration actually reduce the risk for prostate cancer. So that is proven. The other thing that is also a risk factor that we can't do anything about is the race, the black race. It's known to be uh, to have it's known to be more common amongst the people of black race.
Africans.
Yes, Africans, and then it's known to even be more aggressive amongst them because the black race population have a higher concentration of testosterone in them. Yeah.
It's good to know that a lot of things, a lot of misconceptions are actually being cleared out. Like when we spoke with the doctor from earlier, some misconceptions were cleared out. I'm happy you also cleared this one out. So whatever you are thinking is a cause of prostate cancer, my dear, it's not the cause. You just heard from the doctor's mouth. So let's go into the treatment options in Nigeria.
Yeah.
I want to know the treatment options that are present in Nigeria. Are they up to standard? Are they up to par? And are there easy access to them?
Yeah. Thank you very much. So basically, the treatment of cancer, especially solid tumors, um, range from surgery to systemic treatments with chemotherapy or some targeted therapy like immunotherapy and all the systemic medications. And then there's also radiotherapy. All right. So basically, we have very brilliant surgeons that can actually do cancer surgeries. They are also training and retraining to know international best practice and also implement them right here. For chemotherapy, most of the chemotherapy drugs are actually available, but we have some targeted therapies that are not available or may not be accessible or affordable for patients. Access is a challenge when it comes to many of those drugs because they are not essential drugs on WHO list. And then, so when they have to come in, they will come at the rates that they're getting it in the countries. So, and then the fact that our dollar to naira rate is not really um, encouraging. So it makes those drugs unusually very expensive. There's availability of radiotherapy, and I can tell you that radiotherapy in Nigeria is one of the cheapest that you can get in the whole world.
Wow.
All right. So although access, we have a lot of access here in Lagos. We have a number of centers in Lagos that offer radiotherapy facility. But when you look at the machine to the ratio of the population of Nigerians, you will know that Nigeria is underserved. All right. We have for the whole country about over 200 million people. We have maybe just about 10 to 14 radiotherapy machine, and we have maybe about three centers in Lagos. and we have some other centers scattered all over the country. So people will have to move into those places where they can access radiotherapy machine. And these are some of the factors that actually make people encouraged to seek care or not to seek care. Yeah.
So, but particularly now, the biggest barrier to accessing care is the fact that we have more patients than the facilities on ground.
Yeah, of course. I mean, for Nigeria as a country, you're having a population of 200, over 200 million. And then we have maybe about 10 to 14 machines currently working. And then we have maybe less than 70 oncologists in the whole Nigeria. I mean, you could tell that the doctors are overburdened by the number of patients that they will be seeing. All right, so it's a lot. We need more people to get into training and then become specialists. But we also need the government to also show support by investing in healthcare infrastructure, training, negotiation, making policies that would actually help these drugs or the machines or the facilities to even be accessible to the people.
So now, it brings me down to public awareness of cancer. Do you think in Nigeria that the public awareness is improving, or is it getting better? And do you remember, is there any scenario, any story, real life experience of someone who got aware in public and that awareness led to that person getting screening early?
Yeah, basically, I mean, we do outreaches and then we do awareness programs and all that. And we've been able to pick 1, 2, 3 persons, a lot of people followed up, find out that there's something going on, and then they're able to follow through with treatment. We have a lot of people like that. Generally, I think the awareness so far is adequate. All right. I'm speaking not because I'm in Lagos, but because now the world is a global village, because there's social media. So it's not until you go out to speak to people. We have people on social media also giving out this information in ways that people can understand. We have a number of doctors on social media, apropos doctor, and the likes of them coming out to tell us a lot of things about this cancer, especially during that period. And we have some colleagues that also, on TV interviews just to give some more awareness or information about this. And social media, it helps. There may not be a face to it, but you see a lot of information on social media. So are people aware? I think adequately they are. Adequately, I think we can do better, especially in the rural communities. We can also cover more. But adequately, I think people are aware. Now, the question is, to what extent are they willing to seek help? Many a times people use the word, what you don't know will not kill you. So they prefer not to know, because if they know, they have the funds to go through the treatment. That's another thing that we need to start looking at. So if you are making awareness, you are screening people, do we have standard of due process or standard process through which these patients will go through without the treatment being a burden to them? It's important to know that cancer care globally is expensive. Not an individual cannot personally fund its own treatment. Even in the developed world, in the US, in the UK, you have to be on insurance to be able to access and be able to get through the treatment. So And that's the reason why I feel the awareness and screening programs has not really picked up in Nigeria. Why? Because if you go out there and you tell people about getting screened, and then they get screened and you pick a disease, and then majority cannot afford it. Some will be able to afford it, but majority cannot afford to go through that journey. And the next thing is, so what's the point? All right. That doesn't mean that we shouldn't continue with our awareness, because the people that can afford it will still benefit from the care. But if you look at it in the long run, I mean, people will be discouraged, because when they pick up the disease, they are not able to fund the treatment. So what is the point? And that's a question that we get. So we need the government to also help with funding healthcare. We know government alone cannot fund healthcare. There must be interest from private individuals, but we should have a standard health insurance that should cover not just malaria and typhoid or what have you. It should also cover this cancer care to a large extent. All right. So basically, that's what I think.
Thank you so much, Doctor. At least what I know is that, like I said earlier, and I'm saying it with this doctor right here, is that instead of people to get aware, I'm the one getting aware right here, because some things that I actually do not know, not understand before, and I'm getting to understand. One last thing, Doctor, I would like you to actually talk to people who are already in this phase of cancer. What would you say to them? What kind of hope and encouragement can you give to them?
Yeah, so basically, I'll say.
This one that you want to say, look at the camera to say it.
Yeah, so basically, I'll say that it's important to get screened and get treated. Early treatment, early screening or early diagnosis actually would most likely lead to a cure for the cancers. There are many cancers that can be cured if they are picked early. So the journey may be rough, but I just want to encourage us that there's light at the end of the tunnel. God bless you.
Thank you so much, sir. You've heard it. Cancer affects many lives. Cancer has actually done harm to many who didn't detect it early enough, who were not aware about it. Cancer has gone a long way, but then early detection, awareness will make you win and also overcome fear. I am Faith Oyewole, so remain aware and remain alert. Bye.